Let's move on to episode 2 here, which is optimizing outcomes through collaborative care, kind of some post-op review stuff. I happen to believe that eye care is probably the best example or one of the best example in all of medicine, how collaborative care can function at its highest possible level. If we have, both ophthalmology and optometry pulling the same rope in the same direction. One of my mentors always said ophthalmology and optometry are two sides of the same coin. And in order for our patients to have the very best experience and best outcome, both sides of the coin have to be at the very top of our game. There's got to be really good, primary care and optometric community and good diagnostic and referral capabilities. And there's got to be really good, excellent, efficient, elegant surgery that's done when it's needed. In my opinion, I actually believe that, and I doubt that I'm alone, that optimizing outcomes actually starts way before the surgery even occurs. I think that, as we had touched on in episode 1, ensuring that our patients are showing up as tuned up as possible is the best way to get a jump start, a leg up on getting great outcomes. I think if you have a patient that shows up with a pristine ocular surface and a really good educational foundation of, I'm going to have to make a choice on my lenses. I know I'm going to have some options and a rough outline of what those options are. It's super, super helpful for both the patient and for the surgical team of our optometrists and ophthalmologists. So I'll start with, again, Dr. Steiner. What are some of the best ways that our referring colleagues can help ensure that the patient is set up for success even prior to arrival at our offices?
Yeah, I think you're right. I think we already touched a little bit on some of this stuff, but first and foremost, having the talk and the conversation with the patients that probably they've had a long history of knowing. So, what are your goals? And then sharing those with us. So to your point, if it's going to be monovision, how much monovision, which eye's distance, which eye's near, how long have they done it in contacts? Has there been any struggles with monovision? So any details pertaining to that is really helpful. Ocular surface is so important. And even if the patients have already started a dry eye regimen, the education about the differences between dry eye symptoms and cataract symptoms is also super important, because every single patient comes in and says, well, my vision's blurry and that's why I'm here, and trying to get to the root of why is the vision blurry and sorting out what's cataract and what's dry eye. And when I talk with patients during their evaluation, we try to sort that out, but just as long as they know your eyes are dry, you've had a history of dryness, it's being treated, but you're still going to have some of that afterwards that can create some symptoms. I think as long as those conversations are happening ahead of time, it's less frustrating on the back end.
Yeah.
Those would be the two big ones.
Dr. Nguyen, what do you got?
I think too, with like patients that are suspicious for glaucoma or even managing them for a while, just having that additional information ahead of time, but then also making sure that they're on a management if you think that they're going to be a good candidate for a mixed procedure. Sometimes insurance does need to see that there have been previous treatments in place ahead of time before you do that, versus having them come in thinking maybe they might be a good candidate, but not starting them on a drop sometimes can make it difficult for us too.
Yeah, and I think that you're both right on the money. I think the other thing would be setting the table. I mean, it doesn't require a 45-minute conversation, but I think setting the table for expectations and limitations of certain technology and options. I mean, I know that we've all seen patients come through and they're like, well, I don't know why I need to have an astigmatism correcting lens because my neighbor had surgery and they don't need glasses, and they did the one that insurance pays for. So that's the one that I want. And it's tricky because that patient is sitting in front of you with 3 diopters of astigmatism and a lamellar macular hole. And that's the way it always works. And so I think that education on the front end can help save chair time for both referring doctors and us on the back end. I think if you're sitting in clinic and you have a tablet up or a laptop up or a printout of a macula OCT, if you have one in your clinic, and showing them, hey, you have this thing called an epiretinal membrane, it's starting to distort your, the anatomy of your retina, and that's going to affect how you see. And even with a excellent cataract surgery, this is still going to be here. And so you might notice after surgery, my right eye is not quite as good as my left eye, and that's okay. I think a patient knowing that going in is way better for them on the back end. It also does a lot for, I believe, patient trust in the referring doctor as well, because there are often times where I'll get a referral note that says, patient has epiretinal membrane in the left eye. I do believe it's limiting vision. Just know that going into surgery. And then we talk to the patient and say, well, you have this epiretinal membrane in the left eye. And there's, well, Dr. So-and-so never told me about that. Why didn't they see it? And I'm like, they did see it. I know that they saw it. And it's just a communication issue. And if they're told that on the front end, and then it's confirmed and also discussed when we talk to them, they're sitting there saying, yeah, I knew that. And, my optometrist is really good because they already told me about all that stuff and I know what I'm dealing with here. And so I think that it both helps prepare the patient and also strengthens relationships with, patient and referring doctor to have some of those discussions ahead of time. And then I think that as far as the ocular surface thing and the previous refractive surgery monovision things, I think, as you had said, tuning them up as much as you possibly can from an ocular surface standpoint only helps us. Knowing if they've tried monofocal contact lenses and tolerated it well is super helpful for us. And then knowing if they have had previous refractive surgery, letting us know what it was and how they did with that only helps us on the back end. So that's mostly before surgery stuff. What about as far as after surgery? Dr. Nguyen, what do you think are the biggest keys to the post-operative management to help kind of ensure that our patients are extracting as much benefit from these surgeries as they possibly can?
We said it preoperatively, optimizing the ocular surface. I think that still carries forward even in the post-operative care too. And so, especially during the first 4 to 6 hours, I usually say it's going to be super irritated, scratchy. A lot of folks may not anticipate that. And so letting them know ahead of time, but then also saying, hey, these lubricating drops are here for you for a reason. Use them as often as you need to. I think that really helps. Letting them know too, just like what the vision's going to look like afterwards, especially if we anticipate there is going to be some edema if they have a denser cataract. Letting them know, hey, it's going to be fuzzy for a while, but as long as we continue to use these medicated drops, that's going to really help. It'll take more time compared to, Bobby over there, but it's going to get better for you.
Sure.
I think those are key things, is just kind of telling them what to anticipate during the care. I think will optimize things for them.
Yeah. What about you, Dr. Steiner?
Yeah, I agree. I mean, I think you can't probably overeducate a patient. So, if there's probably 2 different ways to look at it. If they're standard lenses where we know they're going to need glasses after, then just a little bit of hand holding between the time they had surgery to when they need the glasses, to explain, here you're not at your optimum vision yet because you don't have the updated glasses to see where things are going to be when you get them. And then, I think a little bit different path or route if it's a premium lens and we're, trying to get them out of glasses. If we're a little bit off target, then just making sure those patients are getting back to us in a timely manner. Lots of conversations in the meantime about, hey, there's maybe a little bit of residual astigmatism. We'll touch that up, but there's a bit of a wait period until we want to do that. We have to let things stabilize first.
Yeah, I think you're right on the money too with having it be difficult to overeducate somebody. I think that there are patients that will kind of start to cut you off when they're like not interested anymore in hearing more details. But I think I would way rather overeducate people, and I would also way rather undersell and overdeliver. I think I would way rather promise less, thinking that we're going to deliver more, than the opposite, and having people's expectations align closer with reality. I think that's how you end up with people who are happier and do better.